Hello, everyone. This is Gabrielle Altit. I'm a neonatologist at the Montreal Children's Hospital, which is at the McGill University Health Center. Welcome to one of the Neocardio Lab module on near-infrared spectroscopy, and it's used in the neonatal intensive care unit. And I'm hoping to bring some elements of research into practice. So the objectives of this presentation is understanding the principles of near-infrared spectroscopy, as well as review some of the evidence on the use of NIRS in neonatal populations. Before ongoing with the presentation, I would like to just present the Neocardio Lab website, which this module will be posted on. You can access the Neocardio Lab website at www.neocardiolab.com. And within the actual website, you can find various modules for teaching on TN echo, point of care ultrasound, as well as congenital heart defects. So within the TN echo portal, you can see that there's an example of all of the views for the assessment of a normal neonatal echocardiography. And you can also see that there are various echocardiography images of different congenital heart disease, for example, such as here, tricuspid atresia. So that being said, I will talk about the core of this module, which is about NIRS. So the plan of the presentation is we will review some of the current monitoring of newborns in the NICU, what are the NIRS principle and the current state of evidence. So as you know, newborns undergo a transitional period, which is critical and may affect organ perfusion. So after birth, typically babies will have expansion of their lungs and drop in pulmonary vascular resistance that is exponential in the postnatal age. And this process of decrease in PVR is secondary to pulmonary vasodilatation in the context of exposure to oxygen, as well as stretching mechanisms of the lungs and various molecular cascades that leads to smooth muscle relaxation in the pulmonary vasculature. And so you get a rush of blood flow within the pulmonary vasculature, and you get concomitantly a very sharp rise in systemic vascular resistance, which is due to the fact that there's the loss of placental circulation, which is a very low resistance circuit. So these shifts that are occurring during the transitional period leads to shifts and changes in resistances, as well as volume of flow within these different compartments. And as you know, there's various newborn conditions that can happen, which can be influenced or influencing this whole process. So you can think about babies being born with extreme prematurity, which have persistent shunts. And because of these shunts, they may have shifts within blood flow in the different compartments. You can think of babies with congenital heart defects, those with hypoxic ischemic encephalopathy, which have often concomitant acute pulmonary hypertension, where these drop in pulmonary vascular resistances or even some injury to or inflammatory reactions to some of the various vessels may be leading to changes in these blood flows mechanisms. So typically in the NICU, we are going to address some of these conditions, and every single newborn is different, as you know, but really the goal of care is to maintain adequate cerebral and organ perfusion in the setting of this changing physiology and during the pathological conditions that we encounter. So how do we monitor our newborns in the immediate postnatal transition? So usually there are indirect ways of measuring end organ perfusion. And the most common way we tend to monitor our baby in our NICU, at least, is by looking at some of these markers that are often the reflection of late reflection of end organ perfusion. So you can think of using your clinical exams, so capillary refill time, pulses, the color of the baby, the liver edge, how much urine output, what's the level of consciousness, and how these markers can actually be influenced by either the pathological state, but also as being very either late markers of end organ hypoperfusion or also being very subjective, to not being able to really accurately measure the degree of end organ hypoperfusion. Blood pressure can be done invasively with arterial lines or umbilical arterial catheters, or measured non-invasively. And other vital signs such as heart rate and saturometry will be useful to give you some perspective on how the baby is behaving. But really, blood pressure is, a very also subjective cutoff of number. There's no number telling you that there's end organ hypoperfusion, and it doesn't mean that you have normal blood pressure numbers that you're having a normal perfusion to certain organs. You can think of laboratory investigations such as lactate, acidosis, creatinine when looking at renal conditions or factors that may influence renal perfusion. And these markers will provide you some information, but it might be limited on the degree of perfusion or hypoperfusion, as well as the timing for your intervention. And often these markers of ischemia are appearing late once the organ hypoperfusion is already ongoing. So the key point number one is that really there's currently no rapid hypoperfusion detection mechanism within NICUs. And it's often by putting the whole story, the exam, all these lab investigation, all these trends within these various markers that you're able to kind of make a sense of what's happening with the baby. But as I hope to have discussed with you, it's often not very instantaneous and maybe not the best to detect when there's early or ongoing ischemia before there's actually tissue damage. So when we're doing early goal-directed treatment in hypoperfusion, most studies within other populations, so pediatric adults, have shown that you improve the outcome and prevent tissue damage. And so ideally, you would like to replicate this within the newborn population, and you would like to have an optimal management of your critically ill neonates by enhancing your ability to monitor quickly and accurately the organ perfusion and possibly act on it. So in some of the pediatric adult ICU, often we will use the central venous pressure, the venous oxygen saturation, the central venous oxygen saturations as way to invasively monitor the hemodynamics of the patients in a live manner. And as you know, these monitoring techniques are, will tell you various information on filling, on your RV and diastolic pressures, as well as your cardiac output. But it's very limited to use these techniques in small newborns, especially when you're dealing with some of the most precarious preemies that are very tiny, because you need to put some of these catheters that can also lead to some degree of injury, infections. You can cause damage to some of the vessels, clots. So it's not very practically being used in most NICUs. So we need new modalities to monitor some of the blood flow disturbances in the precarious newborns to avoid organ injury. And the question is, could NIRS augment the monitoring and improve outcomes? And by augment, I want to tell, not necessarily replace what is being done with all of the modalities that I've previously outlined, but actually, add on as a piece of information and as a trigger mechanism to be worried about certain patients. So this is a nice review in Frontiers of Pediatrics, and outlining that maybe NIRS and functional echo are being used in clinical practice and could be of use to monitor end organ perfusion. And there are other, novel parameters that are being currently evaluated in the research context. So what's the principles around near-infrared spectroscopy? Near-infrared spectroscopy monitors will use regional tissue, will monitor what we call regional tissue oxygenation. And this is a surrogate of systemic and brain perfusion to enhance ongoing management of perfusion. It what it estimates is the venous weighted percent of saturated hemoglobin in the monitored tissue. So depending on the tissue that you're looking, either the cerebral one, the renal, or the splanchnic, you will obtain a number of what should be an estimation of the venous weighted amount of percent saturated hemoglobin. And we know that regional oxygen saturation is dependent on local perfusion, systemic oxygenation, CO2, local extraction, metabolic rate, concentration, type of hemoglobin. And we'll go over some of these concepts as we go along this presentation. So what we try to derive from the NIRS is a value of venous saturation. So you know that your oxygen consumption within an organ, such as the brain, is dependent on the amount of oxygen it's getting on one side, and then the amount of oxygen that is delivered on the other side in the venous compartment will tell you how much oxygen the brain has extracted or the tissue has extracted. And all of this is dependent on your cardiac output and the amount of hemoglobin you have. So a drop in your SVO2 could be related to the fact that either you don't have enough cardiac output to meet the oxygen needs, or either enough blood flow delivery to your organ. Maybe your hemoglobin is too low to provide enough oxygen to the actual organ that is trying to extract this oxygen. Maybe actually the oxygen saturation here in the arterial compartment is too low. So you have lung disease, you have a pulmonary embolus, you're not able to obtain oxygen from the environment because you're in a hypoxic environment. Then obviously your brain is going to have difficulty to extract whatever oxygen is there in the first place. And then if your metabolic demand is starting to increase, then maybe you don't have enough oxygen delivery, for example, to meet that demand. So think of a highway as a blood vessel. And on your highway, you have little cars, and these cars are the hemoglobin. And your hemoglobin will carry the oxygen. And if there's no process causing an issue to deliver the oxygen in terms of either the hemoglobin itself is able to detach the oxygen molecule or attach oxygen molecule within the lungs, well, then you have within the arterial component a nice hemoglobin that has 4 sites. The 4 sites are being saturated with hemoglobin. And if these 4 sites are saturated with hemoglobin, you have 100% saturation. So as this car is traveling through the blood vessel and your oxygen is being extracted to be used, you end up with a car in your venous compartment with 1 oxygen molecule less. And then you have within these 4 seats of the car, only 3 molecules of oxygen left. And so you have a venous saturation of 75%. And this tell you, this is a reflection of what we call venous saturation of oxygen. And what you're trying to measure with NIRS is going to be an estimate of this locally. And so this whole process of oxygen extraction can be dependent on various factors. So you can think of whatever's driving the car, so the motor. So if, for example, you have a problem with your pump or you have a blockage in your pump, then your cardiac output may be impacted and the blood flow within this vessel might be impacted. And so this will change the amount of oxygen that the brain will extract. So you can think of this car advancing very slowly or stagnating here. Well, the brain, which is constantly needing the oxygen to be able to function, is going to, extract oxygen, extract oxygen, extract oxygen. If this car is kind of staying still here, eventually we'll really not have any more oxygen molecules on it. And so arriving in the venous compartment, your saturation will start dropping. Same thing if your metabolic demand is changing. So you can think of a baby who has a seizure, is really demanding a lot of oxygen. Then it's going to extract a lot of oxygen. Another way is if you think of a brain that is completely stunned or a tissue that is actually not extracting oxygen, then in the venous compartment, your saturation will start to rise, because if you don't have any metabolic demand, then you don't need that much oxygen. So think of a newborn with severe brain injury, brain damage that has a lot of tissue necrosis. Think of any kind of tissue that has mitochondrial dysfunction. So, some of the LPS from bacteria will block the mitochondria from using the oxygen. And as such, you might have some tissue damage ongoing and tissue, quote unquote, hypoxia, but one of the reasons is because you're not able to extract the oxygen. You can think of the actual vessel itself. So think of a thrombosis. If you're blocking completely the highway, these cars will never be able to get to the tissue that are needing the oxygen. And so your venous compartment saturation might start drop or rise depending on the blood flow redistribution. And so if you have thrombosis, but also if the tone starts changing, so think of a vasoconstriction or a vasodilation, will really affect the amount of blood flow that's going through the actual tissue. So for the brain, we know that CO2 and pH will have a tendency to it could impact your either mechanisms of constriction or dilation. And also if you have, brain bleeds or seizures, that also can change the tone of those vessels and may also affect the amount of blood flow that's going through the tissue. And so if you have more cars, going through this highway, then the brain will extract whatever it needs. So if you have 10 cars going through and it only needs 1 molecule of oxygen, it will just extract that 1 molecule of oxygen, versus if you have 1 car going through. And that's why, being a saturation that we measure, you have to keep that in mind. So when you're looking at the saturation. And then finally, what is happening in the arterial compartment will affect what's happening in the venous. If you're starting with a saturation here at 75%, so if you have only 3 molecules here, and you're going through and you're removing 1 molecule of oxygen, you'll end up with 2 molecules here, and your venous sat will be 50%. So you can't expect to have a venous saturation higher than your arterial saturation. So you have to put this into context. So as an example, if you're starting with 2 cars, one is completely saturated, the other one is partially saturated, you have 87.5%, you remove only 1 molecule of oxygen, and then at the end, you're at 75%. If on the other hand, now you have 4 cars, these 2 are saturated 100%, these 2 are saturated at 75%, still the same mean saturation. This time the brain has extracted 2 molecules of oxygen, so 1 from here, 1 from here. So you're still at 75%. Same saturation numbers, but more amount of absolute oxygen molecule delivered. So NIRS will give you a sense of information on extraction, but you have to put all of this into context. And your arterial saturation does not necessarily equal the amount of perfusion or the amount of blood flow or cars getting to your brain or to your tissue, but it's really a parameter to take into account in oxygen delivery. And same thing, NIRS informs an oxygen extraction. So NIRS has undergone extensive technical refinement and testing in experimental and clinical settings since its introduction by Jopsis in 1977. And now we can see some monitors like this. This is one of the monitors out there, but there's various companies doing monitors for NIRS monitoring. And you can now monitor with probes that are for adult, peds, and newborns. So typically, we apply the NIRS sensors on various tissue that you're interested in. So in the NICU, we're often interested in looking at what's happening at the level of the brain or cerebral cortex. And the kidney could be an interesting site because it's a postductal organ that also has some degree of autoregulation, but typically will be greatly affected if you're trying to preserve some other organs. So we know, for example, in AKI from hypoxic ischemic encephalopathy process, when you have some degree of perineal distress, well, the kidney might be affected because it's one of these watershed area of the body. You're trying to preserve your blood flow and your oxygen. You're going to send it to your heart and to your brain. So the little probe will be sending some light emitting diode, and you're going to have surface and deep photodetector through which then you're able, by the infrared light, to obtain some measurements through which the algorithm of the machines will provide you an estimate of that venous saturation, venous weighted saturation. Now, Just practicality in babies, you always have to be careful whenever you're applying any kind of saturation probes, that the material needs to be, first of all, make sure that you're using one sensor for one baby. You don't want to start sharing sensors because of infection control. You want to make sure that you're going to be looking at the skin under the sensors at least once a day, but if not more. Because we can have either allergic reaction, irritation, some of the skins are more sensitive to others, and just you want to make sure there's no burns behind it because temperature could rise from infrared, and we've seen it with some other oxygen saturation probe, although it's very rare, but especially in the preemies, you have to be careful because they're more fragile babies, and with any kind of device, their skin is extremely sensitive to it. So we have been, at least locally, very careful with that. And we've also been using some of the other types of dressings, adhesive dressing, in order to solidify some of these probes. But you have to be careful when you're using any kind of these adhesives, and you have to refer to the manual and to the experts from the companies that are going to be selling either the probes or the monitors, and be specific with your equipment, and train obviously all your personnel to be at ease with monitoring. The other thing is that these probes are typically not compatible with MRI, so be sure that you remove it prior to any kind of MRI. So let's put the value in perspective. The venous weighted saturation is a physiological factors that can be influencing the oxygen availability. So you can think of, we said cardiac output, local blood flow, perfusion, but also anatomical variability. So we spoke about vascular structure that are different, clots, disruption of vessels. You can think of regional vasodilation or constriction. So if you have a loss of autoregulation during seizures, you can think also of issues with vascular integrity. So the disruption with a large bleed and local underfilling. The hemoglobin dissociation curve can affect the amount you're going to be extracting. So you can think of fetal hemoglobin versus adult hemoglobin might be different. If you have certain type of dyshemoglobinemia, or if you're having some toxicity with carbon monoxide or methemoglobinemia that with INO exposure can cause change in your oxygen transport. The underlying structures, so if you have on the skin a big hematoma, if you're having some muscles twitching, then underlying you're going to have some increased oxygen consumption just from the muscle structure. So fasciculation is an example of that. So if you put a NIRS probe on your forearm and you start contracting a lot your hand, you're going to see the NIRS value on the monitor start to drop. Blood pH will have, or blood PCO2 will have an impact on vascular tone. The vascular permeability can change hemoglobin content, the local metabolic demand. So NIRS values are impacted by all of these and reflect the amount of oxygen consumed. Hence, trends towards a drop or an increase needs to be interpreted by the clinical situation. So this is a nice little translational neuroscience article where they actually took piglets, and what they saw is they had the cerebral saturation value, they had the muscle saturation value, they had the kidney in red, and they had the gut in orange on these 4.2 kilo piglets. They started clamping some of these arteries. So first, here an example where they clamped the renal artery, and you can see very rapidly a drop in the measure of renal saturation. And then as soon as the artery is released, boom, there's back to its baseline value. Same thing with the brain. So cerebral here is around 90%, and then you drop you bilaterally occlude the carotids of the piglets, and then you have a drop up to 30% until the release, and eventually this comes back. And same thing with the superior mesenteric artery and the gut. This group also look at the data between males and females, adults, as well as dark skin, light skin, and they didn't see really much differences in measurements. So importance, key point number 3 is that you have to look at the trends. And I'm going to be referring to CSAT values and RSAT values at the cerebral and the renal saturation. So what's the current state of evidence? I'm going to start with normal newborns. So this particular study recruited healthy newborns during periods of rest and feeding in the first few days of life to establish baseline normal values. They did a prospective data collection of CSAT and RSAT. They put NIRS on probes on the forehead and on the right flanks around T12 and L2 for the right kidney for both the cerebral and the renal regional oxygen saturation measurements. They recruited 26 patients, among which there were 13 males, and the average CSAT values was around 77%, and RSAT was around 87%, which kind of makes sense because typically the brain in babies will be a high oxygen consumption. It tends to have more metabolic demand than the renal tissue per se. So it's going to extract typically a bit more oxygen than the kidney. This other group measured cerebral, renal, and splanchnic tissue oxygenation saturation. They did it on day of life 1 and day of life 2 of prospectively recruited term newborns without any other medical conditions. And they had 38 subjects. And they had similar values and similar results for both the cerebral and the renal saturation, as you see 78, 78, and 92 and 89. So similar as the previous groups. And then finally, this article reported on 999 infants that were born less than 32 weeks. They were monitored with NIRS during their first 72 hours, and they used mixed effect modeling to generate reference curves grouped by 2 weeks of gestational age. So they've done it for the 24-25 weeker, for the 26-27 weeker, the 28-29 weeker, and babies at 30-31 weeks. And this is really, to tell you that there are some normative values that have been described out there to give us some reference of what to expect. So what about congenital heart defects? So this report, looked at the use of NIRS in pediatric cardiac surgery, and they found that it could detect events such as catastrophic accidental cannula misplacement in the middle of the surgery. There's also another group that looked at the NIRS used in pediatric aortic coarctation repair. They recruited 26 patients, and they found that there was a decline of the renal saturation during the aortic cross-clamping, which was rapid and large and suggested an impairment of renal perfusion, presumably from a lack of adequate collateral circulation to the monitored regional tissue. There was also another study that looked at 11 patients looking at cerebral regional oxygenation during aortic coarctation repair in the pediatric population. And what they found is that if you're cross-clamping proximally compared to distal to the left carotid artery, you're going to have various changes in your cerebral saturation. So you get significantly decrease in your CSAT when it's proximal compared to distal, which makes sense. Physiologically, you get a bit more perfusion to your brain when you cross-clamp distally. This other study is a study that is a randomized control trial, but it's in the adult population. They monitored cerebral saturation in the coronary artery bypass setting, and they found that this avoids profound cerebral desaturation and is associated with fewer incidents of major organ dysfunction. And finally, of interest, there's this study named Comparisons of Different Near-Infrared Spectroscopy Cerebral Oxygenation Indices with Central Venous and Jugular Venous Oxygen Saturation in Children. And what they found is that there was a significant correlation between the CSAT and the internal jugular vein hemoglobin saturation levels in children. So it seems to be a good correlate to the SVO2. So now I want to tackle some of the data because we know there's a lot of this technology already implemented within pediatric ICUs and congenital heart defect population for either pediatric anesthesia or post-cardiac care. So this particular study was done on 41 neonates undergoing bypass, and they measured NIRS and lactate at 20 time points from baseline 1 day pre-op to 24 hours post-operatively. They measured and they found that there was no difference between the left and the right C saturation. So it seems that biparietal cerebral NIRS is probably not warranted, which for newborns, it brings the possibility of using only one sensors in the middle of the forehead, especially that they're typically very tiny. So having more pieces of equipment puts you at more risk of, complications from either a skin irritation or actually not getting appropriate measurements when the forehead is so small. So perioperatively, values of low CSAT, so below 45%. And you remember our term newborns without any conditions had typically cerebral saturation more in the 75, 78 ranges. But in this population, if you had less than 45% and renal saturation less than 40%, and again, remember, put in perspective with the term newborn, which had renal saturation in the 90s, here this correlated with the outcome of ECMO or death. In survivors, very low renal saturation correlated with prolonged ICU stay. And both the cerebral and lactate levels showed a strong inverse correlation during the first 6 hours postoperatively. So here you can see the mean lactate level and the mean RSATs. And as the lactate is rising, you can see here the cerebral SAT kind of dropping, indicating that there's probably some degree of cerebral hypoperfusion. So this other group looked at the population of hypoplastic left heart syndrome, which is a condition in which there's a lot of potential of blood flow redistribution. So they recruited a pretty large population of hypoplasts, 214, with which they looked at NIRS data. They had an early survival rate of 92% and ECMO of 9%. Monitoring in the 48 hours post stage 1 palliation was done. And what they found is that the mean arterial pressure, the cerebral and renal SAT, were significantly higher in the survivors compared to the non-survivors. And when doing a multivariate analysis, they found that cerebral and renal SAT, heart rate, and mean arterial pressure were predictors of early mortality or ECMO. This particular study was a prospective one using CSAT by NIRS, and their main outcome was to look at the post-operative mortality and neurodevelopment as assessed by the Bayley scale type 2. They looked at the mental and motor scores at 6, 15, or 21 months. Their poor outcome was either death or a Bayley score less than 70 at the most recent follow-up. They had 75 infants that underwent neonatal cardiac surgery, out of which 40 were considered to be a single ventricular physiology. They had 14 patients that had a death outcome with 7 lost to follow-up. The survivors with follow-up, so 54, in them, you can see that there was 25 of them with an abnormal Bayley, so close to half of the population. So patients with overall poor outcomes, or either abnormal Bayley or death, had low mean cerebral saturation 16 minutes post being off the cardiopulmonary bypass, and as well 24 hours post-op. They had higher lactate and higher inotropic scores at 24 hours post-op. So we can see that these CSATs that are low in this particular population, so less than 50% here, less than 50% there, were probably a signal towards bad later outcome. They did a multivariable regression analysis in which CSAT and lactate at 24 hours post-op had good accuracy for an optimal value cutoff of less than 58% and more than 7.4 of lactate being associated with the poor outcome. This is a study actually that I have published while being a postdoctoral student at Stanford University. We looked at our population of patients with single ventricular physiologies, and we looked at those with either hypoplastic left heart syndrome compared to those with tricuspid atresia or pulmonary atresia intact septum. So this is typically the extreme of having a ductal dependent systemic circulation. And typically these patients were part of a group where they had some pulmonary dependent ductal circulation. So the primary objective was to measure changes in cerebral and renal saturation the first 72 hours of life. And the secondary objective was to see if the renal saturation values were correlating some of the echo marker of perfusion. So we had a small cohort, but despite the small cohort, this is one of the large population of patients with single ventricles described out there using NIRS, since these are relatively rare congenital heart defects. So first, we divided them as you remember, the left-sided lesion, the hypoplast, and the right-sided lesion. And the left-sided lesion are in blue, and the right-sided lesion are in orange. And you can see that the renal sat will kind of have a drop as you go along the time, in average over the course of 72 hours. And this is really thought to be secondary to kind of the PVRs dropping and more blood flow going through the PDA to the lungs because of this shift in SVR and PVR. So your RSAT, your renal sat there's probably a drop because physiologically there might be a steal effect on the organ perfusion to the kidneys. When looking at the cerebral saturation, you can see that it's kind of maintained around the 64, 66 trademark for our patients with hypoplast, but actually those with a pulmonary dependent circulation, as the PVR drops, there might be also an effect of steal effect on the brain. And we were postulating what could be the reason of that. And there might be an effect that, hypoplasts have been exposed to this degree of brain hypoperfusion throughout their fetal life, and there might have been some auto-regulation mechanisms that have been implemented there during fetal life, while those with pulmonary dependent circulation via the PDA might not have some of these auto-regulation system in place and might suffer from a bit more of this steal effect. Now, we looked also at what we call the fractional tissue oxygen extraction. What is the FTOE? It's when we look at the systemic saturation in terms of arterial compartment measures of oxygen compared to the cerebral or the renal sat divided by the SpO2. So it's SpO2 minus either CSAT or RSAT divided by SpO2 as a measure of oxygen extraction based on what's the underlying saturation. And we looked at the renal FTOE, the cerebral FTOE here in blue and brown for the left-sided lesion, and we did the same for the right-sided lesion. And you can see that there's, as you go along, there seems to be kind of a trend to maybe an increase in the FTOE of most organs, except possibly the cerebral one of the hypoplastic left heart. And this rise might be because there's more and more ongoing oxygen extraction as there's steal effect happening. We then compared them to our controls, mostly to make sure that we have some valid and robust ways of measuring our CSAT and RSAT values. And as you can see, the controls, which are here in orange, have what we would expect for cerebral saturation and renal saturation values. With renal sats around the 90% trademark, like our previous data sets that has been described in the literature. And same thing for the cerebral sat around the 80 and 84%, like the study I had described at the beginning of this module. We also found that there was a weak correlation between the RSAT and the aortic Doppler of the descending aorta. What about other population cardiac? So this group looked at, it's the group of Dr. Chalk from Stanford, at which I studied with, under which I studied. Dr. Chalk described 38 neonates with HIE that were cooled, and half of them developed a definition of AKI, acute kidney injury. And they found that those with acute kidney injury had higher renal saturation levels, which makes sense. You have acute kidney injury, maybe you have tissue damage, tissue necrosis, so then you're extracting maybe a bit less oxygen. This group also, sorry, not this group, but another group looked at 33 newborns, piglets, with a model of hypoxic ischemia where they ligate the carotids or occlude the carotids. And they found that NIRS detected acute changes in CSAT and was highly sensitive for hypoxic ischemia of the brain. The group of McGill University actually looked at their own cohorts of patients undergoing therapeutic hypothermia. So 18 patients with HIE cooled. They found that the cerebral saturation was higher in those who developed later brain injury, Barkovich scoring system for brain injury score on MRI. And the sensitivity within the first 10 hours of hypothermia treatment for adverse outcome of brain injury was close to 100. Well, actually was measured at 100% with specificity of 83%. And this is thought to be that either these patients with more brain injury have less brain activity, more brain necrosis, and less need for oxygen delivery. So as such, the oxygen NIRS values, the CSAT values will be higher. The other reason could be that some of these patients have much more seizure, and then they get treated with anti-seizure medication, and as such, the brain is kind of anesthetized, or the metabolic activity of the brain drastically drops. And as such, these babies will have higher CSAT values because they're just extracting less oxygen. Looking at the preemie population, one of the population we care a lot for in our unit at least. This first group recruited 32 very low birth weight newborns requiring mechanical ventilation, supplemental oxygen, invasive blood pressure monitoring. They did NIRS monitoring from day 1 to day 3 of life, and those with decreased cerebral saturation had higher likelihood of developing severe intraventricular hemorrhage or periventricular leukomalacia. The group of Dr. Chalk at Stanford described 47 newborns less than 29 weeks. They defined hemodynamically significant ductus by echocardiography measurements using the largest diameter retrograde aortic blood flow or left atrial enlargement measurements. They found that 21 had this definition, 14 with non-significant duct, and 12 had no echo due to low clinical suspicion of PDA. They did their logistic regression, and they found that RSAD was associated with hemodynamically significant duct, probably because the duct is leading to left to right shunting and more diastolic steal effect in the pulmonary circulation, and as such may lead to kidney hypoperfusion. And so they did ROC curve, and they found that RSAT less than 66% in these patients identified with pretty good sensitivity and specificity those with what they consider to be a hemodynamically significant duct. This particular group did an observational study on 127 babies less than 32 weeks. They applied NIRS and amplitude integrated EEG at birth, and they did had ultrasound at 12 and 72 hours of life. They found 13 of these babies to have IVH or a mortality outcome, and those who developed severe IVH or mortality had significantly lower cerebral saturation already at 8 to 10 minutes of life. And so they also found a threshold around 66% of CSAT at 7 to 10 minutes had a higher sensitivity and specificity for this bad outcome. The group from CHU Saint-Justine at the University of Montreal recruited infants less than 28 weeks with pulmonary hemorrhage or severe IVH. So they had 8 patients, and they compared them to 11 preemie controls. And they looked at them in the first 72 hours of life, and they found specific patterns of cerebral saturation and oximetry that were significantly different in those with the pulmonary hemorrhage IVH compared to control. And the thought is that, you know, these are markers of diastolic steal secondary to potentially the ductus. The group also described 20 patients less than 28 weeks that underwent echo at 6, 24, 40 hours of life and 72 hours of life. And they measured CSAT continuously until 72 hours, and they found that CSAT strongly correlated with low estimated cardiac output by echo. Finally, the group of Chalk did a multi-center study on premature newborns. Less than 1,250 grams from 6 NICUs. They monitored cerebral saturation continuously until 96 hours of age. They had 103 patients recruited with a mean gestational age of 26 weeks. And the primary adverse outcome was mortality before discharge and intraventricular hemorrhage grade 3 or 4, or PVL in the first 10 days of life. They had 21 patients, 20% that died or had severe neuroradiographic abnormalities, and the adverse outcome had, in general, lower mean cerebral saturation, so 67 versus 72. And they found that CSAT less than 50% identified as a cut point for identifying those with the most adverse outcomes. So I think my key point number 5 is that in general, those with low CSAT and RSAT values within neonates are those with a tendency to have more adverse outcomes. This is a nice little article published in 2020, again, by the group of Chalk, Dr. Chalk from Stanford. And then she goes through some of these cases that are very nicely presented about how trends within the CSAT and RSAT values may help you identify those with, for example, low CO2, in which you need to address your ventilation, or looking at those with decrease urine output and adjustments with some of these medication. So it's just nicely presented in various population example as how could you integrate this monitoring tool in your patient care, and how this may be useful within the context of various others monitoring tools. So, example that I want to give you is for, a patient who's on AEEG and cerebral saturation monitoring and is under therapeutic hypothermia. If you see your CSAT suddenly drop, well, it could be because the baby is seizing. And so you look back at your AEG, sometimes AEG is more subtle, and then finally you might see the seizure appearing. So it just may be a good, monitoring tool to add to your arsenal of different elements as a kind of a new vital sign way to monitor some of these critically ill newborns. So I hope this module was useful. I want to thank you for your attention. I want to thank the Department of Pediatrics at McGill University for their support via their startup funds. I want to thank the Just for Kids Foundation because they did support the Neocardio Lab for the acquisition of the Echo Machine and Top Tech Arena software. I want to thank also Medtronic, our lab applied for a grant, and they provided via peer-reviewed process a material grant via NIRS monitors and NIRS probes. And so I've put my emails there. If there's any question, please feel free. I'm, exploring the world of NIRS and neonatal hemodynamics, as probably many of you, and I won't pretend that I'm an expert or that I know everything, but hopefully some of my experience and some of my readings and research will allow to get a bit more sense of what's happening on these hemodynamics changes of our critically ill newborns. I hope this module was useful, and please do not hesitate to visit the website and to send an email about suggestions, comments about the content of these modules. Thank you.